Penetrating injuries to the chest can cause a collapsed lung or pneumothorax. A simple pneumothorax occurs when there is an open wound that allows air to enter the chest cavity or when the lung is injured, resulting in a leak of air from the lung. Air in the chest cavity causes the lung to fall away from the rib cavity and collapse, resulting in shortness of breath and pain. A more serious condition can occur when the wound tissues create a valve that allows air to enter the chest cavity and not exit, slowly increasing the pressure in the chest cavity. If the pressure in the chest becomes high enough, the heart and blood vessels of the chest can be pushed to the opposite side of the body, resulting in a rapid decrease in blood pressure and death. This condition is called a tension pneumothorax and is diagnosed in patients that have a significant shortness of breath and a fall in blood pressure or shock. The easiest way to determine whether the victim has a tension pneumothorax is to determine whether the windpipe or trachea is in the middle of the neck, as seen in a simple pneumothorax, or pressed to the opposite side of the injury by the pressure within the chest cavity. The position of the trachea can be determined by confirming if the trachea is in the middle by looking or feeling. If it is pushed to the opposite side, a tension pneumothorax is present and should be quickly relieved. Immediate treatment of a tension pneumothorax is done by relieving the increased pressure in the chest by creating an opening in the chest wall to allow the air under pressure to escape. This is done by inserting a needle catheter into the chest cavity. The technique of needle insertion is important to reduce the chance of injury to the lung or chest structures and ensure that the needle is in the right place to relieve the pressure. A needle decompression catheter is inserted perpendicularly to the chest wall at a 90-degree angle just above the third rib in the mid-portion of the clavicle. The insertion site should be as close to the upper portion of the third rib as possible to avoid blood vessels that are located just under the lower portion of each rib. The catheter is slowly advanced approximately 1 to 2 inches into the chest, and a gush of air is generally heard. The inner needle is then removed, leaving the catheter in the chest to equalize the internal and external pressures. A simple pneumothorax or needle decompression tension pneumothorax should be treated by application of a vented halo dressing to the wound on the front portion of the chest to stop the continued flow of air into the lung cavity through the wound. The injured lung may continue to leak air into the chest cavity, resulting in a slowly increasing chest pressure. The valve in the vented dressing allows air in the chest cavity to exit during exhalation and prevents air to re-enter the chest during inhalation. The halo dressing is removed from the resealable packet and the protective film is removed from the back of the dressing. The central window of the sticky gel dressing should be centered over the chest wound, and the edges of the dressing should be firmly applied to the chest to ensure a complete seal. The victim should be quickly assessed to determine whether there is a single entry wound or if an exit wound is also present. Wounds in the back of the chest should be treated by the application of a non-vented occlusive halo dressing. The central window of the sticky gel dressing should be centered over the chest wound, and the edges of the dressing should be firmly applied to the chest to ensure a complete seal. The victim should be monitored closely for any signs of respiratory distress and transported to a higher level of care rapidly.